So good morning, everyone. Want to take this opportunity to welcome David Lee from the Brigham and Women's Hospital. Um, we've had a long-standing collaboration with David, so we're very grateful that he's here to present the talk today. David graduated from UPenn and then went on to do med school in NYU, followed by residency at Columbia in New York, and then subsequently a clinical and research fellowship at Brigham and Women's Hospital and MGH for my fellowship. He's currently associate professor at the Brigham and Women's Hospital and Mass General. He is he's active mainly in the clinical and translational research field, and he's done quite outstanding work in several fields, which include onconephrology, acute kidney injury, as well as several other non-nephrology related research projects which he's gone into. He has published over 100 peer-reviewed manuscripts in high-impact journals. He is now an elected member of the American Society of Clinical Investigation this year. He has been on the editorial board of CJASN, Kidney International, and currently is serving as an associate editor of JASN. He has, in addition to his own lab, in which he's doing the translational work, one of his big accomplishments has been establishment of a network across maybe 50, 60, I don't know the exact number of institutions that collaborate in multi-institutional observational research. And we have been fortunate to be one of those institutions which have collaborated with him in several big projects, and he's going to talk about target trial emulation today using observational data. Thank you, David.
Thanks so much. Thanks, Amit, and thanks, Michelle, for the invitation. It's great to be doing this in person. Like everything is on Zoom these days, and it's refreshing. I guess we're getting Jessica in Boston in a week or two. So let me minimize this. Okay. All right. So yes, a little bit non-traditional to talk for renal grad rounds, but I think hopefully it'll be interesting to you and may open up your opportunities for expanding your research portfolio into more unconventional areas. Okay, so these are my disclosures. None of these are relevant to the talk, with the exception of BTG International did fund one of the studies that I'll talk about, the one on glucarpidase. Okay, so if we take a step back and we think about the two flavors of clinical research, we of course have RCTs and we have observational studies. Randomized clinical trials, as we know, are the gold standard for establishing efficacy, but they are expensive and slow. And as a result, they are often underpowered. They often rely on surrogate endpoints, and they often have limited generalizability. Observational studies, on the other hand, are subject to residual confounding, but they can be helpful in identifying risk factors and prognostication. They can inform the design of future RCTs, and most importantly, they can inform clinical decision-making when data from RCTs are unavailable. And most of the things that we do in medicine, we don't have RCT evidence to back them up. And the goal of this talk is not to say that RCTs are not important. Most of what I used to do was RCTs, and pretty much all of my funding from the NIH, almost every grant I've ever gotten has been to do an RCT or to use data from an RCT. So RCTs are incredibly important. That's why they're the ice cream sundae. But sometimes a vanilla milkshake is all that you need. So the question isn't, is there any role for observational studies? I think the question is, how do we make the most out of observational studies? And I would argue that the best way to do it is with a technique called target trial emulation, or TTE. So what is TTE? TTE is a causal inference methodology that incorporates features of RCT design to minimize bias in the analysis of observational data. So you can think of this as in two steps. The first step is imagine what your ideal RCT would look like. You have infinite resources, time. What population would you study? What would be your eligibility criteria? What would be your intervention? How would you deal with crossover? So actually, the best background to be a TTEist is to be a clinical trialist. Because if you run clinical trials, you understand all the challenges that come up, and you try to incorporate those features into the observational study directly. So that was step one. Step two is that you collect and analyze your observational data in a way that emulates that target trial as closely as possible. This is Miguel Hernan. Miguel is a statistician at the School of Public Health at Harvard, and he's arguably the father of target trial emulation. And I was very fortunate to have learned TTE directly from Miguel during the pandemic. He was actually stranded in Spain for much of the pandemic, and he'd get on these Zoom calls with us at 2 o'clock in the morning, his time. I guess that's not that late in Spain. But we, you know, we didn't have any funding for him, and he really helped us. And I'm just going to read you a quote or two from Miguel, because he says it better than I possibly could. We actually, before I read we actually put this exact quote in the response letter to one of the journals, where they asked, well, what's the why TTE? Why not just a traditional observational study? We don't understand what's the benefit. Traditional observational studies that do not try to explicitly emulate a target trial have resulted in erroneous findings, such as the conclusion that postmenopausal hormone therapy was associated with a 30% lower risk of coronary artery disease, or that statin therapy was associated with a 44% lower risk of death in cancer patients. These findings become null, as they should be, when the observational analysis is designed to explicitly emulate the corresponding target trial. And when Miguel actually went back and redid the analyses the right way, meaning with target trial emulation, he found the same thing that the RCTs found. And Miguel has published, you know, in the New England Journal about target trial emulation. I was fortunate enough that that he and I published together in JAMA. Just a short, piece. They have this section on statistics and methods, where you basically described it in lay terms what this is. And if you'll allow me to just read a couple more. So causal inference involves specifying a causal question and answering it. The question is articulated in the form of the target trial protocol, which incorporates eligibility criteria, treatment assignment, start and end of follow-up, outcomes, and a data analysis plan, just like you would have in an actual RCT. Emulating randomization generally requires data on prognostic factors that are associated with treatment decisions. If all such confounders were correctly measured and adjusted for, there would be no difference between a randomized trial and an observational analysis emulating. So I underline if all such confounders were correctly measured, because that is a high bar. And we were talking at dinner last night about how there are now increasingly large data sets out there that use nationwide data from Epic or in Trinetics. The key, though, is the data granularity. And, I'm not that impressed when I see a study with 1 million patients in it that rely on ICD codes, because we all know that the limitations there. So here are 4 key principles of how you actually do a target trial. So the first is relatively simple. You would use similar eligibility criteria as you would for the corresponding RCT. It sounds simple, but you'd be surprised how many people don't do that when they're formulating a TTE. For example, if you have a patient who clearly would not be eligible for the corresponding RCT, you should exclude that patient from the observational study. Don't just try to adjust for the differences, because adjustment may be incomplete. Just exclude the patient. That first principle is actually one of the most important principles of target trial emulation. It doesn't require any fancy statistics. It just requires you to be in the mindset of a clinical trialist. The second principle is to use the same time zero for both groups to avoid immortal time bias. Immortal time bias is something we don't have to worry about in an RCT, because patients are generally randomized to one intervention or another at the same point in time. In an observational study, on the other hand, you can run into trouble with immortal time bias if there is a delay between your time zero and receipt of some intervention. And the time in between is called immortal time, because you were forced to survive long enough to get the intervention in the first place. A ridiculous example of immortal time bias would be if ICU patients were offered tea and crumpets on ICU day 3. Subsequent analysis would likely find that tea and crumpet recipients have lower mortality than tea and crumpet non-recipients. You can tell this was a British author since they're talking about tea and crumpets. But of course, well, they had to, because they had to survive long enough to get the tea and crumpets in the first place. Another way that I would explain it is this quick video.
A recent study has found that birthdays are good for your health. Researchers found that people with more birthdays live longer than those who have fewer. A recent study.
There's and you could, there's all sorts of examples you can come up with. People who smoke more, people who have more pack years of smoking live longer than people who smoke fewer. Hopefully you get the point. In practice, actually accounting for time for this immoral time bias, it ends up being one of the trickier things to do. The third step is to adjust for detailed baseline confounders to emulate random treatment assignment. And of course, there are different ways of adjusting. Regression is the most common, but there's also matching. There's also inverse probability weighting. It's not that one is better than the other necessarily. The most important thing isn't which method you use, it's having those detailed data in the first place. And then the fourth principle is analysis by the intention to treat principle. The idea of comparing the effect of being assigned to treatment A versus treatment B at baseline, regardless of potential crossover later on. Anyone who does clinical trials knows this is the gold standard way for analyzing a clinical trial. But when is the last time you saw this in an observational study that they talk about intention to treat? And right, it doesn't. You don't generally see that, but it actually makes sense. If someone crosses over, you don't get to just pretend that they didn't. There wasn't a reason for the crossover. You should keep them in the group they were originally assigned. So we have applied target trial emulation to a whole bunch of different areas, ranging from COVID to babesiosis, not something you have to deal with here in Colorado, to onconephrology. Most of my research is on AKI, but I love internal medicine, and I consider myself an internal medicine doctor first and a nephrologist second. I'm sure many of you feel the same way. And if I get interested in something, I'll just run with it, even if it's not nephrology. So during the pandemic, early on, and particularly in the setting of critical illness, the initial studies were very limited. They were limited by small sample size, poor data granularity, short follow-up, and limited generalizability, because most of the studies were single-centered. So there was a huge unmet need for the creation of a large, detailed, nationally representative database of critically ill patients with COVID in the US. Such a database would include detailed data on demographics, comorbidities, symptoms, and all the other things you see here. So I reached out to Michelle, and as you can see, you can see Colorado here on the bubble map. I reached out to Michelle and to colleagues all across the country. I said, let's get together and I don't have any funding, but let's get together and put the largest and most detailed data set that in critically ill patients with COVID that anyone's ever done. And Michelle said, great, and he introduced me to Anit, and it's been a wonderful collaboration for six years now and ongoing, well beyond just COVID. And so I'll just talk about the COVID study briefly, because I think everyone's sick of COVID and we want to get into the more recent stuff. But this is a study where we ended up enrolling over 5,000 patients across 68 medical centers with over 400 collaborators. These collaborators ranged from medical students all the way up to attendings. And people volunteered their time, they really believed in the project, and it was really inspiring. We ended up collecting over 800 data elements per patient, all by manual chart review. Oh, and I should mention, so Shruti Gupta is my superstar mentee. Many of you may know her. She's doing terrific. She was on a K23 at the time. Looks like she's about to get her first R01. And she and I, did this project together. And she did a lot of the onconephrology stuff that I'm going to talk about. She had an integral role as well. So we used REDCap to collect the data. REDCap is a HIPAA-compliant, web-based data collection platform. It's very user-friendly. It's very user-friendly on the front end. On the back end, there are a lot of advanced features like branching logic, automated data validation, and again, all data were extracted by manual chart review, which took 1 to 2 hours per patient. And so you can do the math with 5,000 patients. So the primary goals of the study were first to study the clinical features and outcomes in these patients, including things like AKI, to assess inter-hospital variation in treatment and outcomes, which is actually really interesting, looking at how, and I don't have time to get into it today, but there were major differences in outcomes, just depending on which hospital you were admitted to. And then, most importantly, to perform causal inference analyses of the effects of treatments on outcomes using target trial emulation. So I just want to go through the initial timeline because it was pretty crazy. So between mid-March and mid-April, so over the course of basically just 1 month, we built the REDCap database with 800 plus questions, established collaborations with 65 medical centers. This would eventually be 68, but initially it was 65, executed 65 separate IRB approvals and 65 separate data use agreements, and collected data on the initial roughly 2,000 patients. Eventually it would be over 5,000 patients. We then gave ourselves 3 days to clean and validate the database, which at this point had roughly 2 million data points. We then gave ourselves 3 additional days to analyze the data, write the initial paper, make all figures and tables, including 20 plus supplemental figures and tables, and collate the comments from 200 co-authors. We actually had, there were so many co-authors, we actually had to have like team leaders. We had like 5 groups of people to review the comments from, you're going to do California, and Texas, you're going to do whatever. And so it was pretty crazy. And then on April 21st, we submitted our first paper to the New England Journal of Medicine. It did not get into the New England Journal of Medicine, sadly. But over the course of the ensuing months and years, we ended up publishing over 25 papers from Stop COVID in journals like PNJ and JAMA, IM, Annals, JASON, and it was truly a wonderful collaboration. And it's not just that the number, it's forget about number of papers. The most impactful papers were the target trial emulations. Specifically, these are the 4 areas that we looked at. I'm going to talk about tocilizumab just as an example, and then I'm going to skip the other ones. So tocilizumab, as many of you may know, is a recombinant humanized monoclonal antibody against the IL-6 receptor. It's used to treat vasculitis and cytokine release syndrome, for example, in patients who have received CAR T therapy. The dose is 8 mg per kg IV once. Onset is within 4 hours. The half-life is roughly 2 weeks, and it costs about $5,000 a dose. Now, why examine toci in COVID-19? Well, hyperinflammation was identified early on as an important driver of morbidity and mortality. We knew this from the UK's recovery trial, where they found a major benefit with dexamethasone. And then there were also reports that higher circulating IL-6 was linked with worse outcomes. So we sought to use our data to answer the question, does early treatment with toci improve survival in critically ill patients? So we published this in JAMA IM on October 20th, 2020, and a recurring theme will be Anip's name in a lot of these papers. So just like you would have a flowchart in an RCT, here's our flowchart. And these are some of the key exclusion criteria. So we looked on clinicaltrials.gov because there were ongoing RCTs of toci, and to see why were patients being excluded in the trials. And if you had a transaminitis over 500, you got excluded because there have been rare reports that toci can cause liver injury. So that's just an example. If you had already received toci, so if you had been in the ICU for more than 7 days. So basically, we tried to copy the eligibility criteria as closely as we could. We ended up with roughly 4,000 patients who we categorized. We can't say we randomized them, but we categorized them according to whether or not they received toci within the first 2 days of ICU admission. 433 received toci and the others did not. Now, these are some of the baseline characteristics, and I've just highlighted a few things. So the toci treated patients tended to be younger, and they tended to have fewer comorbidities. They also tended to be sicker. So they were more likely to have hypoxemia, which we defined as a P to F ratio less than 200. And they were more likely to be inflamed. And we defined inflammation using a combination of markers like ferritin, D-dimer, CRP. So that's not good, right? In an RCT, you want everything to be balanced at baseline. So we used a technique known as inverse probability weighting to adjust for confounding. Inverse probability weighting is a propensity score-based approach where patients are assigned a certain amount of weight according to their likelihood of receiving or not receiving an intervention. In this case, the intervention being tocilizumab. According to 28 pre-specified variables that you see on the y-axis. And we pre-specified these variables as things that potentially might influence a physician's decision to prescribe TOSI and might also be associated with the outcome of death. In other words, these are the potential confounders. And on the x-axis, this is called the absolute standardized difference. You may remember back to college level biostatistics, learning about something called the Cohen's effect size, where an effect size of 0.2 is generally small, 0.5 is moderate, 0.8 is large. So the reason why there's a dotted line at 0.2 is because anything greater than 0.2 is considered more than a small difference between groups. And the black circles represent the unweighted population. So this is before we applied inverse probability weighting. And as you can see, there are several variables that are certainly to the right of 0.2. But after we applied the weighting, you can see the red triangles, everything is to the left of 0.2. It's basically just a visual way of showing that the inverse probability of weighting worked to create a pseudo population of patients that looked similar at baseline, at least with respect to these 28 variables. And we found that TOSI-treated patients had improved survival. You can see that with the Kaplan-Meier curve on the left. You can see it with the Cox model on the right, with an adjusted hazard ratio of 0.71, or roughly a 30% lower risk of death. In terms of subgroups, interestingly, patients who had fewer days from symptom onset to ICU admission tended to have more benefit from TOSI, which I'll come back to in a second. So, drum roll, how do these results compare with subsequent RCTs of TOSI in COVID-19? So, the very same day that we published our paper in JAMA IM, October 20th, 2020, the very same journal published 2 negative RCTs. And the very next day, the New England Journal of Medicine published a negative RCT. So imagine, thousands of hours of work have gone into this, and we're really excited about our findings. And now, within 24 hours of our paper, there are 3 negative RCTs. I start getting phone calls or emails from reporters that don't usually contact me because they're not usually interested in AKI. But so it's cool that USA Today, Washington Post, CNN, and they saw my article. It's interesting, but how do I make sense of the fact that we have these negative RCTs? And I said the RCTs are wrong. And they said, "Excuse me? You want us? I mean, and some of these reporters are very savvy, actually. I mean, you want us to believe that the 3 RCTs are wrong, but your observational study is correct." And I said, "Yes, because the RCTs were severely underpowered." And that was a point that I made in a letter to the editor at NEJM, where those initial RCTs had to be negative. So, and by the way, this is the study that I'm criticizing is from my own institution. So it was, but I felt strongly enough that because like the New England Journal editor and one of the associate editors, they came out and with a video talking about how this is the end of tocilizumab for COVID, and this proves like that this is the wrong pathway. And so we published this letter, and I said the trial by Stone et al. Was severely underpowered. In the placebo group, the percentage of patients with a primary outcome event, which was intubation or death, was 12.5%, far lower than the anticipated 30%. A post hoc power calculation reveals that with this event rate and with the number of patients enrolled, which is only 243, it would have been nearly impossible for the trial to have shown a significant effect. The risk of the primary outcome would have had to have been 80% lower with TOSI than with placebo. And nothing reduces anything by 80% in medicine. I think aspirin for MI was like 50%. And then we compared the characteristics of our study versus theirs. 100% of ours were in the ICU, compared to 4% of it. So there's very different in terms of the sickness of the patients. So you can imagine I was relieved. Yes,
David, if you would have applied your statistics without doing the 28 variable analysis and left all those patients in, would it have been a negative study?
If we had done an unadjusted analysis?
Yes.
That's interesting. I don't know the answer to that because there was confounding in both directions. The TOSI patients were sicker acutely.
They were younger.
Exactly.
Yeah.
So it's kind of, I don't even think we showed the unadjusted now because it's kind of meaningless.
Yeah, I thought it would have been interesting to put that on that same graph because then you'd have shown the importance of adjustment if it would have been negative.
Well, so what we did do that when I referred to that JAMA Statistics and Medicine piece that Miguel and I published, we basically used the TOSI as an example, and we intentionally screwed up the analysis. we pretended that we were like amateurs, and we showed how if you do it wrong, you get a totally different result. So indirectly, we did what you were suggesting. Yeah. So you can imagine I was quite relieved when a few months later, an adequately powered study that was done specifically in ICU patients was published in the New England Journal by the REMAP CAP group. And this 750 patients and randomized to toci versus control. And indeed, they found a major mortality benefit with toci. And then a few months later, the recovery group from the UK published the largest RCT anyone has ever done, 4,000 patients. Now, these were not just ICU, this was hospitalized patients. Some of them were in the ICU. 4,000 patients randomized to toci versus control, and the 28-day mortality was significantly reduced with toci. Not a huge reduction from an absolute standpoint, 31 versus 35. But remember, this is all comers in the hospital, not just ICU. But interestingly, you remember that subgroup analysis that I showed from our study? So they basically found the same thing. Patients who had fewer days from symptom onset to hospital admission were the ones who tended to benefit the most from toci. So even down to the subgroup level, we were predicting what the RCTs predicted, what the RCTs found. And if you're still not convinced, a few months later, JAMA published a meta-analysis of over 10,000 patients from 27 RCTs. How many things in medicine do we have 27 RCTs for? And indeed found the odds ratio for mortality was 0.83, and you can see from the confidence interval, highly significant. Okay, so I'll just tell you that we also looked at therapeutic anticoagulation, published this in Annals. We found no beneficial effect of anticoagulation, and the subsequent RCTs found the exact same thing. For ECMO and prone positioning, there has never been an RCT, and likely there never will be an RCT in COVID. So arguably the findings from these studies are even more important because that represents the highest level of evidence that we'll ever have. Last thing about Stop COVID. So about a year after we started, USA Today did a story on Stop COVID, and I'd like to just read one of the quotes. Without funding, Stop COVID relied on more than 400 research coordinators, nurses, residents, medical students, and physicians across a range of specialties, all volunteers, to review the charts of more than 5,000 patients and hand enter 800 data points on each. Many times caregivers would finish a grueling shift in the ICU, then come home and spend unpaid hours entering data. And it was really, and then there are people in this room who did that, and it was really inspiring. And this has been a model for me for future studies. And I would actually argue that, it's not getting NIH grants is nice, it's prestigious or whatever, but this type of work has been more impactful than any of my NIH funded stuff. Babesiosis is not something fortunately you need to deal with in Colorado. But although there are some other ticks in Colorado, you have to watch out for. But I'll just tell you briefly about this study because I think it's super interesting. So babesiosis is a tick-borne illness caused by the parasite Babesia microti. This is transmitted by the same tick that transmits Lyme disease, the Zoodes scapularis tick. Now, nobody wants to get Lyme disease, but you don't generally die from Lyme disease. You can die from babesiosis. Babesiosis it's a parasite that infects your red blood cells, and as a result, it can cause massive hemolysis. That's actually how I got interested in this area in the first place. A lot of my research on cardiac surgery associated AKI is related to hemolysis from the bypass circuit. So you can get severe organ injury, including AKI, and death from babesiosis. And rates are rising, probably because of global warming. So I teamed up with the world expert in babesiosis, Peter Krause from Yale, and with one of my trainees, we launched Stop Babesiosis in a similar style as Stop COVID. And we collected data on over 3,000 adults hospitalized with babesiosis across 82 hospitals in the Northeast. This was, existing data on babesiosis are like case reports, or sometimes, maybe a dozen patients, and the authors are, they put in the title the number of patients because there's so, 13 patients from Long Island with babesiosis. So it's not, it's anecdotal. It's not really rigorous that you can do anything with it. So to get 3,000 patients for this relatively uncommon disease was important in terms of being able to do rigorous analyses. And one of the key questions we wanted to answer was looking at the efficacy of RBC exchange transfusion. So exchange transfusion is often used in patients with severe babesiosis, patients where antibiotics alone are not enough. The only way to get the parasite out is to basically remove all of your RBCs while simultaneously transfusing your entire blood volume. So patients can get 10 to 12 units of PRBCs. But you know, it's an invasive procedure. You need a central line. You often need to be in the ICU, and data supporting its clinical efficacy are severely lacking. So we just published this a few weeks ago in JAMA IM. We had so many co-authors they couldn't even fit. So we just call it the Stop Babesiosis Investigators. But we did a target trial emulation. I know this is super busy. I'm going to read you every single number now. But we used what's called a sequential TTE design. And this was exactly to eliminate that issue with immortal time bias that I was discussing before. And this will come up on other studies that I'll talk about. But basically, it's not like everyone who comes into the hospital, if they're going to get exchange transfused, they're going to get it on day 1. Some of them might get it on day 7. So if you just did a crude analysis, then you're giving those patients on day 7 days of immortal time, right? They have to survive 7 days in order to get it. So the way to address this is with what's called a sequential design. So you look on each hospital day, we basically said we're going to look at this within the first 7 days of hospital admission. In general, if you're going to get exchange transfused, it's going to be in the first week. On each day you're in the hospital, we look at you and we say, are you eligible? And we had a whole list of eligibility criteria. Are you eligible or not? If you're eligible, then we look, you either got exchange transfused on that day or you didn't get it. We then repeat the process on each day. And so the final analysis is basically 7 separate TTEs, if you will, that we then merge together. But the nice thing about this approach is that it eliminates immortal time bias, because if we're looking at day 6, we're only looking at people who were still alive and hospitalized on day 6. And we're looking at, did they get it or not? But the other nice thing about this is we're not severity of illness. We know by day 6, you could look totally different than how you looked when you showed up in the ER. So we're not adjusting for what the initial presentation, we're adjusting for your severity of illness on that day. So your SOFA score, your creatinine, whether you're on invasive mechanical ventilation, whether you're on pressors. So all that is adjusted for on the day of randomization. And we found that exchange transfusion had a major reduction in parasitemia. That's how you quantify how sick someone is with babesiosis. You actually, under a microscope, you count the number of RBCs that are infected with the parasite. It's kind of gross. And so we saw a 60% relative reduction in parasitemia with exchange transfusion versus 30% in those who did not. And more importantly, we found a major benefit in terms of ET-treated patients had a lower in-hospital death or 30-day readmission, which was our primary composite endpoint. You can see the adjusted odds ratio was 0.22 for ET versus no ET. And if you do this as a time to event analysis, we found the same thing. You can see pretty impressive differences between groups. Okay, enough about babesiosis. This is renal rounds after all. So I want to spend the last few minutes just talking about a few onconephrology studies. So we have done TTEs across a whole bunch of areas in onconephrology. I'm just going to talk about the first 3 on the top here. So glucarpidase and methotrexate associated AKI. So this is a paper that we published in Blood last year. It's actually the first TTE that Blood ever published. Of course, Dr. Bonsall was a major contributor. And so, I should mention I'm married to a hematologist, so it was fun to we get Blood journal in the mail each week, so it was fun to be able to open up one day. So just some quick background. So high dose methotrexate is it's one of the oldest chemotherapies, but we still use it today. It's a cornerstone of treatment for lymphoma and leukemia involving the central nervous system, because it's one of the few chemotherapies that penetrates the blood-brain barrier. High dose methotrexate can cause a variety of toxicities, with AKI being the most common and consequential. Glucarpidase is a recombinant bacterial enzyme that rapidly cleaves and inactivates methotrexate. It's also very expensive. This is a paper published in JCO in 2010, where they basically took 35 patients, they gave them glucarpidase, and they measured methotrexate levels, which you can see over here. And this is very impressive. I mean, the y-axis here is on a log scale. So these are very large reductions, and I highlighted it from the abstract. Plasma methotrexate concentrations decreased within 15 minutes of glucarpidase by 98.7%. Okay, impressive. Intervention, and so, but their conclusion, I totally disagree. Their conclusion was early intervention with the combination of glucoborine and glucarpidase is highly effective in patients who develop high-dose methotrexate-induced renal dysfunction. Highly effective compared to what? Everyone in the study got glucarpidase. There was no control group. So I think I would have added highly effective biochemically, but there was no clinical outcome here. They couldn't have. Everyone got the intervention. So despite its potent biochemical effects, no study has examined glucarpidase's clinical efficacy in patients with high-dose methotrexate toxicity. And again, this is an expensive medication, and so that's what was the motivation for this study. So as a result of this knowledge gap, there is considerable inter-hospital variation in the use of glucarpidase. There are some hospitals, I won't say which ones, not this one, but there are some where they just hate glucarpidase. I don't know why. There's like this one oncologist whose life mission is he just writes editorials all over the place about how, of the lack of data for glucarpidase. But he's right. There was a lack of data, at least until now. And the other thing, as a result of this knowledge gap, is that there's even conflicting guidelines on who should be treated. Our buddy David Goldfarb was on extra. So, using our familiar TTE design, we launched the study to look at the efficacy of glucarpidase in patients with methotrexate AKI. So this is a multi-center cohort study of 708 adults. All of them had methotrexate-associated AKI from 28 major cancer centers across the U.S., including this one. All data were collected by manual review with over 400 data elements per patient. The primary exposure was receipt versus no receipt of glucarpidase within 96 hours of developing AKI. The primary outcome was kidney recovery at discharge. And we defined recovery, so you had to be alive, you had to not be on dialysis, and your serum creatinine had to be less than 50% baseline, consistent with KDIGO criteria. We used a sequential DTE framework, just like we did for the babesiosis project. And of course, multivariable adjustment for demographics, comorbidities, methotrexate levels, and AKI severity. These are the eligibility criteria. So in order to have enough patients, we had to go all the way back, we had to go back 20 years. So from 2000 to 2022, again, they had to have developed AKI. We, of course, excluded them if they had ESKD or if they were morbid. Oops. So these are some of the covariates we adjusted for in the multivariate models. The most important covariates are here, the 24-hour plasma methotrexate levels, and also the maximum fold change in serum creatinine, which is actually a much better way of adjusting for AKI severity than just AKI stage 1, 2, 3. Because you could have a tripling of creatinine and be stage 3, or you could have a 6-fold increase in creatinine and you're still stage 3. So the maximum fold change is actually much more granular. And so we ended up with 708 patients, 209 of whom received glucarpidase, and 499 of whom did not. Just to put this in perspective, even at a large hospital like mine, Brigham/Dana-Farber, we might pull the trigger on glucarpidase once a year. So to get 209 patients that got this expensive drug, that's why we needed 28 sites and 20 years worth of data. You could never do an RCT with this. It would take 20. It would take more than 20 years because not everyone you approach for an RCT agrees to be in the RCT, right? So there never will be an RCT for this. Glucarpidase was administered at a median of 54 hours following methotrexate. These are some of the baseline characteristics. The glucarpidase patients, if anything, tended to have more comorbidities and received more nephrotoxic medications. These are the 24-hour plasma methotrexate levels. You can see the glucarpidase treated patients had much higher levels, and they also had worse AKI. This is the maximum fold change in serum creatinine. So if anything, that would bias you against finding a benefit for glucarpidase. If you're going to see imbalance, you want to see it in this direction. and I won't go through all this, but this is the same sequential TTE design that we used for babesiosis. And we found that glucarpidase treated patients had increased odds of kidney recovery. The adjusted odds ratio was 2.7. This was consistent across a whole bunch of sensitivity analyses. It was consistent in time to event analyses. The oncologists really want to know about not just AKI, but neutropenia and transaminitis, and we found benefits there as well. Okay, I see that it's 1:45. I think I'm going to skip the IV mag part and just go to the last page because it would be sacrilegious not to talk about uric acid since I'm here. So I'm going to skip this. Basically, we found that IV mag seemed to reduce the incidence of cisplatin-associated AKI. So I'm going to skip that. Okay, rasburicase and tumor lysis syndrome. And so this is a study that is actually still under revision. It's under its second revision now at BMJ. So I'm hoping any day now to get the acceptance. So this is a study where we looked at early treatment with rasburicase and risk of kidney replacement therapy and death in adults with TLS. And this was led by Tushar Shenoy, who's currently a first-year med student at the University of Chicago, and Daniel Sanchez Almanzar, who's in my lab and will be starting residency in the fall. So, or not in the fall, and its residency starts in July. So some quick background on TLS. So TLS is an oncologic emergency, most often occurring in patients with heme malignancies with a high cancer burden. A rapid breakdown of tumor cells releases potassium, phosphate, and of course uric acid into the circulation, resulting in high rates of AKI. Now, rasburicase, similar to glucarpidase, is a recombinant urate oxidase that is highly effective in lowering plasma uric acid levels. So there's actually a lot of similarities with glucarpidase. We have this drug that's expensive and it has very potent biochemical effects, but we don't know really don't know anything about its clinical effects. So we collected data on actually over 2,000 adults, but 1,276 ended up being eligible for the target trial from 10 major cancer centers across the US, including here. By now you're familiar with the study design. The primary outcome was KRT or death during the index admission. We used a TTE framework and multivariable adjustment for detailed severity of illness. We had 43 covariates that we adjusted for in these patients, and you can see all of the comorbidities, all of the labs we adjusted for, other treatments that they'd received, and arguably the most important thing was how sick were they when they developed TLS? Were they in the ICU? What was their SOFA score? Did they have AKI? What was their urine output? Pressors, mechanical ventilation, even code status. We really tried to factor everything in. And so, as I said, we had over 2,000 patients, but we excluded patients if they would have been excluded from a hypothetical RCT. And they ended up with 1,276 patients. 705 received rasburicase within the first 12 hours following TLS onset. That was our exposure, 12 hours. We wanted to see, does it matter if you get it early or not? And it turned out it did. So the adjusted odds ratio was 0.67, major benefit for rasburicase. And this was true across 12 sensitivity analyses that the kind BMJ reviewers asked for. And then I know this is small, but in subgroup analyses, patients with lower serum bicarb seem to be the ones that particularly benefited from rasburicase, which actually kind of makes sense if you think about uric acid precipitating in an acidic urine. We didn't have urine pH available because it just wasn't, not because we didn't think to collect it, it just wasn't available in the charts, and a lot of these patients did not have a UA. So we used serum bicarb as a surrogate. And also, interestingly, and this was completely the opposite of my hypothesis, the patients with moderate to severe AKI at the time of TLS onset were the ones who benefited the most. I would have thought once you already have severe AKI, it's too late to give the rasburicase, but that's not what we found. And all sorts of secondary outcomes were significant, and again, time to event analyses were also significant. Now, interestingly, I mentioned the 12 hours. So we also looked at, okay, so there's a benefit at 12 hours. What happens if we expand that exposure window to 18 hours, 24 hours? So you can see as you expand the exposure window, it's still significant at 18 hours, But once you get to 24 hours or later, it's no longer significant. So this suggests that if you give rasburicase is helpful, but only if you give it early, which kind of makes sense. Okay, so just to wrap things up, so the conclusions are that combining, this is the secret sauce that I've kind of developed, is combining TTE methodology with very detailed data, often by manual chart review, with a multi-center approach is a very powerful combination to answering key questions across a whole range of fields, ranging from COVID to AKI. And future directions, in case you were worried that I had stopped there, we're doing target trial emulations for cardiac surgery associated AKI. We're looking at, I'm very interested in acute interstitial nephritis, very interested in some of the TMAs, including scleroderma renal crisis. So if anyone here is interested in that, let me know. And of course, there's so much variation in how we prescribe CRRT. That's a whole other area. So I've mentioned Shruti Gupta, who was played a key role in many of these studies. I want to thank my biostatisticians, my collaborators, without whom this would not be possible. My grant support, but in reality, none of these studies were NIH funded. These are our collaborators for Stop COVID, Amber, Anik. These are our collaborators for Stop Babesiosis. These are our collaborators for